So today in Active Learning Medicos, we are going to learn everything about insulin. So it was discovered by Banting and Best in 1921, and physiology is it's secreted from pancreas. Now pancreas consists of islets of Langerhans, which further consists of alpha cells, beta cells and delta cells. Alpha cells secrete glucagon, beta cells secrete insulin, C-peptide and amylin, and delta cells secrete somatostatin. Now in the human body, proinsulin is actually the molecule which is secreted from the beta cells. Now proinsulin gets then cleaved into insulin and the C-peptides. Now these are secreted in equal amounts. Now use of C-peptide is marker of insulinoma tumor, obviously, because if insulinoma occurs, then the secretion of proinsulin also increases and also the C-peptide secretion increases. Now number 2 use of C-peptide is differentiation between type 1 and type 2 diabetes mellitus. And number 3 is endogenous and exogenous insulin can also be differentiated by use of C-peptide. Now the structure of insulin, since it is a polypeptide hormone, it has two peptide chains, A and B. Now A chain consists of 21 amino acid and B chain consists of 30 amino acids. Now these two chains are linked by disulfide bonds. Now since insulin is a polypeptide hormone, it is not absorbed orally because in oral route of administration, the insulin peptide gets digested by the various gastrointestinal enzymes. Now the mechanism of secretion of insulin from beta cells is very interesting. In beta cells, potassium ion normally gets secreted by the ATP sensitive potassium channel. Now in presence of glucose, when it enters the beta cell, then glycolysis occurs which causes increase in ATP. Now ATP closes the ATP sensitive potassium channel, which causes increase in concentration of potassium ion inside the beta cells. Now this results in insulin secretion from the beta cells. Basically, to summarize, potassium ion inside the cell increases, which depolarizes the cells, which causes fusion of vesicles containing insulin and ultimately increase in insulin secretion due to release of insulin. Now let's see the pattern of release of insulin. So in the y-axis we have insulin and the graph looks like this. Now in the x-axis we have the time of the day where the peaks of increase in insulin is due to the meal. So let's say a person has 3 meals in a day. At the time of the consumption of the meal, the insulin secretion increases. So there are two types of insulin levels in the body. Number 1, the basal insulin, and number 2, the bolus insulin. So as you can see, the bolus insulin are the peaks of rise of insulin secretion due to meal, right? Now bolus insulin has a particular use which controls the postprandial hyperglycemia, PPH, and the basal insulin is used to inhibit catabolism. Now this can either inhibit glycogenolysis or inhibit lipolysis or inhibit gluconeogenesis or inhibit ketogenesis. Now remember that we have to provide the insulin levels in a diabetic patient just like the physiological levels. Therefore, diabetic patients are given two types of insulin. Number 1, bolus insulin, which is given 2 or 3 times a day according to the timing of the meal they are taking, and the basal insulin once daily because the basal amount of insulin secretion must be maintained. Now remember that basal insulin is absent in type 1 diabetes. In type 1 diabetes, the beta cells of pancreas are already damaged. Therefore, basal insulin is also absent and ketogenesis is more in type 1 diabetes. Insulin is degraded by insulinase enzyme. Now this enzyme is present in liver and kidney. Now liver degrades the endogenous insulin produced by the body and kidney degrades the exogenous insulin which are given from outside the body. Since you know the location of the insulinase enzyme, always remember that insulin requires dose reduction in renal failure. Now let us study insulin as a drug. Now number 1, animal insulin. There are many sources of animal insulin including beef insulin or pork insulin. Now beef insulin differs in 3 amino acids from actual human insulin and pork insulin differs in 1 amino acid from humans. Therefore, in this case, pork insulin should be better than beef insulin as it is very similar to the human insulin. Now advantage of using animal insulin, very cheap. Now examples of animal insulin are regular insulin, NPH insulin, neutral protamine H-DON and lente insulin. Number 2, human insulin, also known as humulin, produced by recombinant DNA technology, either produced from E. coli or yeast. Now examples are all the insulins mentioned above. The types of injectable insulin. Now these are ultra short, also known as rapid insulin, short, intermediate and long insulin. So these are based on their duration of action. For the ultra short insulin are Lispro, Aspart and Glulysin. So the mnemonic is LAG. Then short insulin is also known as regular insulin. Now intermediate insulin has two examples, NPH also known as neutral protamine H-DON and lente insulin, and long acting insulin are Detamir, Glargine and Degludec. Now their pattern of release of insulin are as follows. So Lispro, since it's ultra short acting, the insulin level peak rises very sharply. Then the short acting, the peak rises little bit gradually. Then NPH also, since they are intermediate acting, their duration of action is larger and the peak is very gradually reached. And finally long acting insulin, the Glargine and Degludec nearly have no peak at all, but they maintain a long duration of action of insulin release. Then let's compare their onset, peak and duration of action. So onset of ultra short is 15 minutes. For short it's 30 minutes. For intermediate it is 60 minutes and long it is 60 minutes also. Now the ultra short peak is reached within 1.5 hours. So it's very fast. Now short peak reached within 3 hours. Intermediate, the peak is reached within 6 hours. And since I told that Glargine and Degludec do not have peaks, but Detamir has a peak which is reached at 9 hours approximately. Then the duration of action of ultra short is 3 hours. The duration of action of short is 6 hours, intermediate it is 15 hours and long it is 18 hours. Then the only two value you have to remember is Glargine, the duration of action is 24 hours and Degludec, the duration of action is 42 hours. So ultra short insulin are basically insulin molecules which are freeze soluble insulin. Since these are monocomponent insulin, they cause rapid absorption in the body. Now short insulin, basically 6 insulin molecules are attached to a zinc molecule. So these are also known as hexameric zinc insulin. Now the intermediate insulin is same, but here instead of zinc the insulin molecules are attached to protamine, hence the name neutral protamine H-DON. And finally long acting insulin, the insulin molecules are bound to a lipid moiety. Since the lipid moiety takes a longer time to release the insulin, therefore they are long acting insulins. Can you use your logic from the physiology and guess which types of insulin are used as bolus insulin and which types of insulin are used as basal insulin? The ultra short and the short insulin are used as bolus insulin just before the meal, and the intermediate and long insulin are used as basal insulin to keep and maintain the steady insulin secretion during the day. Now using the knowledge that you just learned, try to answer these MCQs. Number 1, peakless insulin are Glargine and Degludec, since these are very long acting. Number 2, shortest acting insulin are Lispro. Number 3, it is the longest is obviously Degludec. Number 4, zinc and protamine is added to make the insulin acting longer, because these take little bit longer to release the insulin in its free form, right? All insulin pH are neutral, which is same as the pH of blood, that is 7.4. Now this property of insulin can be used to combine all types of insulin in a same syringe. Now this is important because you can give a bolus insulin and a basal insulin simultaneously to a patient if you give and combine them in a same syringe. Therefore these type of insulin are also known as mixed-stirred insulin. Now there's an exception to this rule, that is Glargine is not neutral in pH. It is known as acidic insulin. Therefore it must never be combined with other insulins. So you have to use separate syringe to use Glargine. Mixed-stirred insulin can be either a combination of Lispro or NPH, since Lispro is ultra short and NPH is intermediate, or regular or NPH, right? Now this mixed-stirred insulin is usually prepared in the ratio of 30:70 or 50:50. Now let's come to the very easy part, the uses of these types of insulin. So bolus insulin has two types, either ultra short, example Lispro, or short, as I have said, example regular insulin. And basal insulin includes NPH, which is given twice a day since it's intermediate acting, or Glargine once daily, or Degludec once in 2 days. Right. Now bolus insulin obviously are combined and given before meals to control the PPH, postprandial hyperglycemia. And basal insulin, by the basal insulin secretion levels, so they are fixed during any time of the day. Now remember, the lente insulin that you studied under intermediate is already a mixture of two insulin, both bolus and basal level. Now these two insulin are semi-lente and ultra-lente. That semi-lente also known as amorphous insulin, and ultra lente, also known as crystalline insulin. Now these are used in the ratio 30:70. Now the diagram of the release of insulin looks like this. Semi-lente is actually short acting and ultra lente is actually longer acting than semi-lente. Now let's study the chemical modification in insulin. Now I have already shown the normal human insulin looks like this. It consists of two chain, A chain and B chain. A has 21 amino acid and B has 30 amino acid. Now you can actually modify the B chain in the following ways. There are three important amino acids where chemical modification of insulin can be done. Number one, B3 position, where the third amino acid is normally aspartic acid in the normal human insulin. Then the 28th position of B chain, which normally is proline, and the 29th position of the B chain, which normally is lysine. Now keeping this knowledge in mind, let's see the modifications of insulin. So if we modify the 28th position of insulin, we get Lis-Pro. Now if you divide the term Lis-Pro, it consists of Lis and Pro, right? So basically Lis comes first in the 28th, lysine and proline comes in 29th position. Therefore, basically in normal insulin, it is swapped. Number 2 is aspart. Aspartic acid is used. So the position is 28th amino acid. Now the third is glue-lysine. Again divide the term glue and lysine. So glutamic acid is used in 29th position and lysine is used in 3rd position. Finally, we have regular insulin. Since the name only suggests that it is regular, therefore there are no change or no modifications required. Now let's study the various routes of administration of insulin. So the number one, very first route of insulin administration is subcutaneous route. All types of insulin can be administered in this route. So the diagram is roughly this. Subcutaneous fat is the fat consisting just below the layer of the skin, and under the subcutaneous fat there are blood vessels. So if you inject the insulin in the subcutaneous fat, then slowly, gradually the insulin will get absorbed in the blood vessels and reach the bloodstream. Now insulin through subcutaneous route can be used for long time treatment of diabetes mellitus. Therefore subcutaneous injections can be given, subcutaneous pens which have pre-filled insulin can be given, and subcutaneous insulin pumps, they deliver 24/7 continuous insulin supply. Now an important point to remember, which will clarify the subcutaneous route further, is that site of subcutaneous injection are 4, mainly abdomen, like the anterior wall, thigh, the anterior or the lateral wall, number 3 is arm, and number 4 is buttocks. You should never give insulin subcutaneously in the 2 centimeter radius around the umbilicus. Now, since the fat is less, if you give the insulin in this umbilical region, then the insulin will get in the bloodstream very quickly, and that will cause an hypoglycemic shock. Number 2 route of administration is nasal insulin. Yes, insulin can be given through the nasal route. So the example is Afreeza. Now this is inhaled as dry powder form. Now this has ultra short action and therefore it is used before the meals to control PPH. Now it acts for 3 hours. So that's an important point. And since this is an ultra short action insulin, it can be given along with basal injectable insulin. Right. So this peak must be maintained because this is the physiological normal body function of insulin secretion. Now Afreeza does the job of the bolus insulin, and the basal injectable insulin does the job of the maintaining the basal level of insulin secretion. Now a very important point is nasal insulin is contraindicated in asthma or COPD and smokers. Alright, now let's study number 3, intravenous route of insulin injection. Now the drug of choice is regular insulin. Now this is a drug of choice for emergency condition like diabetic ketoacidosis and hyperkalemia. So what happens in diabetic ketoacidosis? Now this is a very dangerous condition since the ketone body in the blood increases. Now the clinical features of this disease is the pH of the blood decreases from 7.2. This occurs since there is acidosis in the body. Now this can present as nausea, vomiting or diarrhea. Now diarrhea can ultimately cause dehydration symptoms. Number 2, fruity odor in breath can be found, and number 3, Kusamal's breathing is found. So the treatment of diabetic ketoacidosis first is plenty of fluids, right? Number 2 is correct the electrolyte imbalance. Now this can be done either by giving sodium bicarbonate or by giving potassium supplements. And number 3, IV regular insulin must be given in this condition to quickly control this emergency condition. So the number 2 emergency condition where intravenous regular insulin must be used is hyperkalemia. Now hyperkalemia is defined when the potassium level in the blood is greater than 5.5 milliequivalent per liter. Normal value of blood potassium level should be 3.5 to 5.5 milliequivalent per liter. So that's a very narrow range. So this is a very serious condition where the treatments are following. Number 1, you have to protect the heart. Now the reason behind this is potassium in blood when enters the heart muscle, it causes cardiac arrest. So excess potassium is very bad. Now this can be treated if we give calcium in the blood, because calcium inhibits this process of potassium uptake in the heart. Therefore the IV drug you have to give is calcium gluconate. Now instead of potassium getting inside the heart, it can be redistributed by the use of insulin in skeletal muscle and adipose tissues. Now redistribution can be done by giving IV regular insulin plus 50% dextrose, because the sugar level is normal in this patient, but if you give only insulin, then the sugar level might fall. So you have to give 50% dextrose solution mixed with it. And also in this case, inhale salbutamol, because salbutamol is a beta 2 agonist. Now beta 2 agonist promotes the insulin secretion. Now insulin causes potassium to be uptake in the blood by the cells, and it also causes release of proton. Now number 3, you have to excrete potassium in urine in cases of hyperkalemia. Now this can be done by using loop diuretics like furosemide. And number 4, you have to correct the acidosis which is occurred due to potassium uptake in the cells, corrected by using sodium bicarbonate. And number 5, you have to reduce the GIT absorption of potassium. Now these can be done by giving potassium binding resins like polystyrene sulfonate, number 2 sorbitol, number 3 patyromar. Now number 6, and the best and most effective treatment of hyperkalemia is hemodialysis. Now this being the most and best effective treatment, this is not used because hemodialysis takes time. And the last and final topic of this video are the side effect of insulin. Now the very important and very common side effect of insulin is hypoglycemia, and it is a dose related. It can also be classified as toxicity of insulin. Now the treatment of hypoglycemia is giving oral or IV glucose or giving intramuscular glucagon. If beta blockers like propranolol are given, then these mask the effect of hypoglycemia to insulin. Now this is very dangerous because the hypoglycemia clinical features are not presented. Now this is also known as hypoglycemic unawareness. Number 2 side effect is hypokalemia, since we know insulin causes potassium uptake in various organs like heart, skeletal muscle and adipose tissue. Number 3, insulin causes weight gain, since insulin is an anabolic hormone. Number 4, insulin causes lipodystrophy, since it causes abnormal growth of fat due to repetitive subcutaneous injection at the same site. Now, therefore, advice given to the patient should be always change the site of the next injection. And number 5, the rare side effect of insulin are allergic reaction to animal insulin. Now this can cause edema or fluid retention. Alright, so that was everything about insulin in pharmacology. Hope you found it very useful. If you want more such summarized videos about any hard topics, then hit the subscribe button right now and write down in the comments what you need next. Click here to learn about this video.